She called me from the hospital parking lot. Her voice was steady, but I could hear something underneath it, something between exhaustion and disbelief. Her husband, 73 years old, had gone in for what they described as a quick check on some mild knee discomfort. 6 days later, he was being discharged with a walker, a new diagnosis, and 4 prescriptions he did not have when he walked through those doors. She said to me, "Dr. Mehta, he went in walking on his own. He's leaving in a wheelchair." And then she asked a question I have heard in different forms from dozens of families over the years. She asked, "How does that happen?" That question deserves a real answer, not a polished one, a real one. And that is exactly what today is about. My name is Dr. Mehta. I specialize in internal medicine with a particular focus on adults over 60 and how the body's response to both illness and intervention changes as we age. What I have spent the last 18 years observing is a pattern that the medical system rarely names out loud, but that shows up with quiet regularity in the lives of people who go into appointments feeling fine and come out managing things they did not have before. Today I want to give that pattern a name, a mechanism, and most importantly, a set of tools you can use to protect yourself or someone you love. Before I give you the list, I want to share one idea that will reframe everything else. I call it the intervention gap. Here's what it means. Every medical intervention, whether it is a test, a prescription, a procedure, or a referral, carries 2 kinds of value. The benefit, which is what we talk about openly and loudly, and the cost, which is what we almost never discuss in the room. For a 50-year-old, the intervention gap is usually narrow. The benefits tend to outweigh the costs clearly, and the body has significant reserves to absorb the friction of treatment. After 65, that gap widens. Benefits often stay the same on paper, but the costs, the side effects, the recovery demands, the downstream consequences quietly grow. The problem is that most medical appointments do not pause to measure that gap. They move toward action because action feels responsible. And for many older adults, it is the action, not the underlying condition, that ends up changing everything. Keep the intervention gap in mind. We are going to return to it over and over. Let us start with number 5. There is a class of medications that are prescribed for sleep, anxiety, and general agitation in adults over 65 so routinely that many people have been taking them for years, without any conversation about what the long-term picture looks like. These are benzodiazepines, brand names like Xanax, Valium, Ativan, Klonopin. If you or someone you love has been prescribed any of these and is over 65, what I'm about to tell you matters. Benzodiazepines were not designed for long-term use in any age group, but in adults over 65, their effects become disproportionately powerful for a specific physiological reason. The liver's ability to metabolize these drugs slows significantly with age, meaning the medication stays in the system far longer than it did when a person was younger. The result is cumulative sedation that builds gradually and becomes difficult to distinguish from the normal symptoms of aging. Slow thinking, difficulty with balance, memory lapses, falls. In fact, benzodiazepine use in older adults has been directly linked in multiple major studies to a significantly elevated risk of falls and hip fractures, which are among the most serious and life-altering events an older adult can experience. There is also a developing body of research examining the association between long-term benzodiazepine use and cognitive decline. The science is still evolving, but the signal is consistent enough that the American Geriatric Society has placed benzodiazepines on what is called the Beers criteria, a formal list of medications considered potentially inappropriate for older adults. What to ask your doctor? How long have I been on this? What was the original reason for prescribing it? And is there a supervised plan to reassess whether I still need it? Abrupt discontinuation is dangerous and should never be done alone. But a structured taper, under medical supervision, is something many older adults have successfully completed, often with significant improvements in clarity, balance, and sleep quality. Number 4, and this one is hiding in plain sight in medicine cabinets across the country. Proton pump inhibitors, PPIs, are among the most widely prescribed medications in the United States. You have heard the brand names: Prilosec, Nexium, Prevacid. They are prescribed for acid reflux, heartburn, and stomach protection. And for short-term use in specific situations, they are genuinely useful. The issue is that a significant number of adults over 65 are taking them continuously long-term without any scheduled reassessment. Here is what that matters physiologically. Stomach acid, which PP is suppress, plays a role that most people do not think about. It is a frontline defense against certain bacteria. It is essential for the absorption of key nutrients including magnesium, calcium, B12, and iron. Long-term PPI use has been associated in observational studies with increased risk of bone fractures due to reduced calcium absorption, increased susceptibility to a dangerous intestinal infection called C. difficile, and in some research, an elevated risk of kidney disease with prolonged use. The deeper irony is that stopping PP is after long-term use can cause a rebound effect, where stomach acid temporarily increases beyond baseline, which often leads people to believe they still need the medication, when what they are experiencing is actually a withdrawal response. I worked with a patient, 71 years old, a former contractor from New Jersey, who had been on a PPI for 9 years. No one had ever suggested a trial off the medication. When we slowly tapered him under supervision with dietary guidance alongside it, his chronic fatigue improved, his B12 levels normalized within 6 months, and he told me he felt like someone had turned the lights back on. What to ask? When was this medication first prescribed? What was the original indication? And can we schedule a supervised reassessment of whether I still need it at this dose? Number 3, and this is the one I want you to stay with because it is the most counterintuitive. There is a medication category called alpha blockers that are commonly prescribed to older men for urinary symptoms related to an enlarged prostate. Flomax is the name most people recognize. For the symptom it targets, it is often effective. But here is what frequently does not make it into the conversation. Alpha blockers cause blood vessel relaxation throughout the body, not just in the prostate. In older adults, this can produce a condition called orthostatic hypotension, a sudden drop in blood pressure when a person stands up from sitting or lying down. That pressure drop triggers dizziness, sometimes lightheadedness, sometimes something closer to blacking out briefly, and it happens in the seconds after standing. In a younger adult, the cardiovascular system compensates quickly. In an adult over 65, that compensation is slower, and the gap between standing and stability is exactly when falls happen. Here is where it becomes a cascade. An older man starts Flomax for urinary symptoms. He has a dizzy episode standing up at night. He falls, he fractures a hip, he has surgery. Post-surgical complications follow. His independence changes permanently, and every step in that chain connects back to a medication prescribed for a quality of life issue, not a life or death condition. I want to be clear, this does not mean alpha blockers are wrong for every older adult. It means the full risk conversation should happen before the prescription is written, and it often does not. Before accepting this prescription, ask about orthostatic hypotension risk specifically. Ask about evening timing and bathroom safety, and ask whether behavioral and dietary approaches have been fully explored first. The conversation you have before starting a medication is infinitely more productive than the one you have after a fall. If what you are hearing today is shifting how you think about healthcare conversations after 65, type the word questions in the comments right now. I read every single comment, and I genuinely want to know who this is reaching. Number 2. This one involves a category of medication that almost no one questions because the name sounds so straightforward. Blood pressure medications. Let me be precise immediately. Uncontrolled hypertension is a serious condition, and treating it is important and often genuinely life-extending. That is not what I am questioning. What I am questioning is the way that blood pressure targets and medication doses established for middle-aged adults are sometimes applied without recalibration to adults in their 70s and 80s, where the physiology is different and where the risks of going too low are just as real as the risks of staying too high. After 70, blood pressure management becomes about finding a range rather than hitting a single number. Here is why. The aging brain adapts to slightly higher baseline pressures to maintain adequate blood flow through narrowed vessels. When medications push pressure too low, even below what would be considered problematic in a younger person, it can produce dizziness, cognitive fog, fatigue, and falls. There is also a phenomenon called supine hypertension, combined with orthostatic hypotension, where blood pressure is elevated lying down, but drops dangerously upon standing. Standard blood pressure readings taken while seated can completely miss this dynamic. I have seen patients referred to me with worsening balance, increasing confusion, and generalized weakness. Patients whose family assumed they were declining from age, who improved meaningfully when their blood pressure targets were simply adjusted to age-appropriate ranges, and their medication doses were revised accordingly. The question is not whether to treat blood pressure after 70. The question is, what target is right for this specific body at this specific age? Ask your doctor, has my blood pressure target been recalibrated for my current age? And have we ever checked what happens to my pressure when I stand up? And number one, the one that generates the most resistance when I bring it up, and the one where I think the data is most important to hear clearly: statins, cholesterol-lowering medications, Lipitor, Crestor, Zocor. These are among the most prescribed medications in the world, and for adults in their 50s and early 60s with a history of cardiovascular events or with high baseline risk. The evidence supporting them is strong. I want to be direct about that. But here is where it gets complicated for adults over 75 who have no prior history of heart attack or stroke, who are taking statins purely as a preventive measure. Multiple major studies, including analysis from the All-Hat trial and subsequent meta-analyses, have found that statin use for primary prevention, meaning preventing a first event in someone who has not had one, shows significantly diminished benefit in adults over 75. What does not diminish is the risk profile. Statins carry a well-documented side effect called statin myopathy, muscle aching and weakness that can range from mild discomfort to a more serious condition called rhabdomyolysis in severe cases. In older adults, muscle weakness is not a minor quality of life inconvenience. It is a fall risk. It is a functional independence issue. It can mean the difference between someone who walks their neighborhood every morning and someone who does not leave the house. There is also emerging evidence around statin use and cognitive effects in older adults, with some patients and practitioners reporting cognitive symptoms that improve upon discontinuation, though research in this area is still developing. I am not here to tell you to stop your statin. I am here to tell you that if you are over 75 and taking a statin for primary prevention, and you have never had a direct conversation with your doctor about whether the benefit still outweighs the risk at your current age, that conversation is overdue. Ask, am I taking this for primary or secondary prevention? Has my doctor reviewed my current risk level given my age? And when did we last reassess whether this medication still belongs in my routine? Now, here's what I want you to walk away with. Every item I have covered today has a common thread. None of them are about abandoning medicine. All of them are about demanding that medicine do the math out loud with you, instead of in a 15-minute appointment where action is assumed. There are 4 questions I want you to have ready at your next appointment. Write them down now. First, was this medication or test originally designed and studied for someone my age? And what does the evidence look like specifically for adults over 65? Second, what is the full side effect profile, including the effects that increase with age or with long-term use? Third, when and how will we reassess whether I still need this? Not just refill it, but actively revisit whether the benefit still outweighs the cost. And fourth, what is the most effective non-pharmacological approach we should try or continue alongside this? And have we fully explored it? A physician who is genuinely practicing geriatric-informed care will not only welcome these questions, they will have already been thinking about them. If those questions are met with frustration or dismissal, that tells you something important about whether the care you are receiving is calibrated to your age and your goals. Here is the one action I want you to take before your next refill or your next appointment. Pull out your current medication list, every single one, and write next to each one just 2 things: why you started it and when that decision was last revisited. That exercise alone, which takes 20 minutes at most, will tell you which conversations you need to have and which prescriptions might deserve a second look. That simple piece of paper, brought into an appointment, changes the dynamic completely. You stop being a passive recipient of a refill, and you become an active participant in a decision. That shift in the room matters more than most people realize. Share this with someone in your life who is managing a parent's health care, a spouse's medications, or their own growing list of prescriptions. The information is straightforward, but it is rarely said this clearly in a medical office. and the people who need it most are often the ones least likely to go looking for it. Subscribe if today changed how you think about this. Next week, I want to talk about something that connects directly to everything you heard today. There are specific questions you can ask in a hospital setting, before a procedure, before a prescription is written, before a follow-up is ordered, that shift the entire conversation, and that most patients never think to ask until after something has already gone wrong. If you or someone you love is navigating any kind of medical care right now, that video is for you. Leave a comment below. Have you ever been on a medication for years without anyone revisiting whether you still need it? Your experience in that comment section might be the exact thing someone else needs to read before their next appointment. I will see you next week.